There may be a few others joining, but welcome everyone to the Alberta Association on Gerontology Living Well, Enhancing Seniors Care and Services Speakers Series. Today is our first session, focusing on living well in the community. I'm Lynn Mansell. I'm a member of AAG, and I'm your host. But before we start, just a few housekeeping details. First of all, in case we reach our maximum attendees, we are wanting to record the session, which if you are not happy with that, could you let us know in the Q&A box. But because this is a webinar, your video and your audio will not show up, and only your questions will be seen in the Q&A box. So as I said, at the bottom of the screen, there's a Q&A button that you can use at any time to ask a question. If you're having any other difficulties, maybe you could type a question in the Q&A box as well, and we'll do our best to respond. Our speakers will talk for about 15 minutes, and when they're finished speaking, we'll have the Q&A period. One last note, we shouldn't be too concerned about Zoom bombing because attendees can't be seen or heard, but if we are targeted in some unexpected way, we may have to terminate the session. Without further ado, I'd like to introduce our speakers, Dr. Sharon Anderson, who is an AAG board member and one of the authors of the AAG Living Well report, and Dr. Richard Lewanczuk, who will now introduce himself and start the presentation.
Hi, everyone. Thanks very much for this opportunity. I'm Richard Lewanczuk, the Senior Medical Director for Health System Integration, which is the new name for what used to be enhancing care in the community. So thanks for this opportunity. Sharon had asked me to address in the area of community living, but to look at the 2030 report and to pick out 3 of the recommendations that came from the community living section, which I have done, and I'll show you in a second. But I just wanted to highlight that from the symposium around the report, it talks about a future in which older Albertans are engaged, empowered, and enabled to achieve quality of life. I might have stopped there, but it says through financial security, social connectedness, and access to healthcare. The reason I might have stopped there, and we'll talk about this in a second, is that I know a lot of Hollywood stars who have lots of financial security. They go to a lot of parties, and they do have private health plans, but they aren't necessarily happy. So I would maybe stop at the quality of life. But if you look at the themes that were identified by the symposium participants, you can see it talks about person-centered care, choice and independence, wellness, living well and happy, integration of health and social services, shifting services from institutions to community, enhancing community capacity, and respecting diversity. So I'm actually going to touch on all of these. And it's sort of a little bit by accident and by design, but it's very nice that it all comes together. So in my world, in Alberta Health Services, when we talk about enhancing care and community, we're referring to enabling people to be as healthy, well, and independent as they can be in their homes and communities. I like, particularly for people involved in healthcare, to say, first of all, we use the term wellness. We don't necessarily always use the term health because we often think that things revolve around health. So if you can imagine that I have a magic pill that I could give you, and that magic pill would give you perfect health. So you would never, ever a day in your life be sick, have an ache, a pain, a headache. You die peacefully in your sleep at age 120 in perfect health. But like all good fables, there's a catch to this. In order to have this perfect health pill, you must agree, first of all, to live homeless, cold, subject to violence, friendless on the streets, but you will have perfect health. So do you want that perfect health pill? So in other words, I think you can see the issue around health versus wellness. So if we actually consider that health is actually only one component of wellness, there's lots of other things that compare to our wellness. So this is the OECD Well-Being Index. There is the Happiness Index. And it's not just about having perfect health. It's about our connections, our social connections, our environment, appropriate incomes, our community, so on and so forth. So I chose the following 3 recommendations from the community part of the recommendations to talk about. The one, number 1.1, about the government to increase proportion of spending on home care, community-based services, etc. The next one about Alberta Health and Seniors and Housing to continue to support an Alberta-wide community-based senior serving sector. But the most important one, I think, is 1.6, to promote the development of innovative design and delivery of services. So that's sort of a bit of my day job. And so let me ask you the question then. So where and how would you like to live as you age? So where would you like to live and how would you like to live? And I guess I could simply answer that question or guess at the answer, or I would probably say, well, I personally want to be as healthy, well, and independent as I can be in my home and community. So that may be one answer to that. We know that the majority of people, and this is from American Association of Retired Persons, but Alberta statistics are the same, Canadian statistics are the same. The large majority of people want to maintain their current residence as they age. In Denmark, for example, at age 75, you get a visit from the healthcare system or the senior system in order to see what is necessary to help you live as long as possible in your own home. But I always feel a little bit of two minds when I talk about this. So sometimes in the days when we used to have in-person meetings, if you can remember that far back, at this point, someone would often put up their hand and say, well, hang on for a second. I have to care for someone who is at home, and it's an incredibly tough job. And so it's easy for you to say, keep people at home, but you know how hard it is for me to do that. And so I do want to acknowledge that fact, and we'll come back to it. But on the other hand, we're caught in a little bit of this tension, you know, as laid out by the WHO and their framework on integrated people-centered health services, which talks about, you know, don't do things to me or for me, but do things with me. So I might say, for example, that as I personally age, I don't want my children to decide, okay, today we're going to put dad into the home. You know, I'll make that decision for myself, please, and thank you. But again, acknowledging that it can be challenging for community-based care, particularly for carers. So from that perspective, then, what is it that we would need to enable you or ourselves or anybody to live in their homes as we age? Well, first of all, I just wanted to highlight, if we look at care and who provides care, first of all, it turns out that 90% of care is provided in the community, informally, either through the form of self-care or by what used to be termed informal caregivers or care partners. That's 90% of care, which leaves 10% to the system. Of 10% of systematic care, 70% of that is provided by the not-for-profit, volunteer, and charitable sector, leaving only 3% of care provided by the healthcare system. And yet we spend 50% of our budget on those hospitals and other structures of the healthcare system, whereas 97% of care is provided other ways. In COVID, 96% of care occurs out in the community. So how do we support people then to age well in their homes and communities? Well, just sort of quickly going down the list, well, we can start with supporting individual supports. How do we help the individual? Well, one way is through providing social supports and supports that maintain independence. So for example, self-management supports. So I personally would prefer to wake up in the morning and be able to brush my hair, brush my teeth, get myself dressed and washed, and not have to wait for somebody to show up at the door to do that for me. In the former instance, I am independent. In the latter instance, I am dependent. And if you know your definitions of dependence and independence and frailty, you might recognize that one of the frailty measures relates to degrees of dependence. And so when I am independent, I'm not frail. As I become dependent, I start to develop frailty. And if you're a healthcare system person, then you know the minute that happens, healthcare costs triple. We, of course, want to support the carers, acknowledging the tremendous amount of work that they do. We need to ensure that the aids to daily living and instrumental aids to daily living, so washing, grooming, dressing, and then meals, cleaning, all of that is available to people. There's the traditional home care type of services, which are sort of medical based. They may be necessary to support people. True medical care, meaning sort of now physicians, can also be necessary to support people. And even at higher degrees, we're always looking at not necessarily putting people into hospital, particularly older people where there's deconditioning, confusion, falls, 17 different sets of things can go wrong according to my last count when you go into a hospital, but rather using the concepts of virtual hospital or complex care hubs to help people, even when they're in acute illness, to manage at home. We often forget about towns and municipalities who, through their design by curb cut downs or transportation services, help people age well in their homes and communities. Businesses, you may be familiar with some businesses. There's one just west of Edmonton where they have a seniors lane, a slower lane where people aren't in a rush and they take time in the grocery store to help with older people. And then the same thing with our communities. In our communities, we can help our neighbors if they happen to be elderly to age well, shoveling their snow, cutting their lawn, just as very simple examples. So lots of things that we can do. I put this slide in to remind myself about the tremendous contribution of carers, but we'll come back to that. One of the things we know from a healthcare system perspective is that if we look at admissions to hospital, but this could also be admissions to long-term care or even supportive living, the older the population, the higher the proportion of admissions. Okay, no surprise there whatsoever. It makes perfect sense. But even in terms of hospital admissions, we know that older people are more likely to end up in a hospital. But let's change the x-axis on that from age to income or resource. So this is people who get the income supplement, so who are at lower income. And you can see that, again, a correlation between poorer or lower incomes or need for resource and hospital admissions. That is independent of age, but also even amongst seniors, that relationship holds. And then we did a third thing. We looked at the supports that are available in people's communities across the province, across our local geographic areas, and we were able to come up with a sort of a codged together index of what was available. And guess what? It turns out that the more supports that are available in the community, the lower the institutionalization rate. Makes perfect common sense, but we sometimes don't actually think about the parallel or the flip side to that is if we provide supports in the community, then we will be able to keep people out of institutions, which is where most of us do not want to be. So what about those resources? Well, often when we talk about resources and what are the resources that might be able to help keep people out of hospital, what's available in the community, we often say that, there are, one of the challenges is that either resources don't exist, or maybe we don't know about them, or maybe they aren't coordinated. I can certainly tell you after about 3 years of being full-time involved in enhancing care in the community or health system integration, this is the situation. I can tell you that the resources do exist. It's just much more that we don't know about them or they aren't coordinated. There are over 25,000 not-for-profit, volunteer, and charitable organizations in Alberta. As of about 2 days ago, this is the Alberta Cares Connector. So if you as a citizen of Alberta would like to explore a volunteer opportunity, this is where you go to. So ever since the Alberta Cares Connector had been sort of renamed and relaunched in the spring, it has had 2.2 million visits. In other words, the majority of the Alberta population, if it's just one visit per person, is actually interested in volunteer opportunities. So the question about, are there enough volunteers available? I think that answers that question. It's not, of course, totally volunteers and volunteerism as well. So going back again, what are the resources that we have to help people manage in the community? Well, we talked about things such as self-care. If you were to put a dollar figure on it, from the Health Quality Council, Government of Alberta, self-care, if it had to be provided by a carer or a paid caregiver, would be worth about at least $1 billion per year. Government of Alberta website tells us that volunteer activities, if you monetize them, provide $9 billion worth of care to individuals. Health Quality Council tells us $3 to $4 billion of services provided by carers or care partners. Estimating from foundation donations and foundations that exist, businesses provide at least $1 billion worth of help and care to individuals. And then municipalities as well have seniors serving services and things like transportation and sidewalk clearing in the winter. If you add this all up, we very quickly get to at least $17 billion, which just happens to be the same amount as the AHS budget. So when we go to the government and say we need more AHS budget, if I was a government member, I'd say, well, have you looked into the other 17 billion that exists out in the community and how is that being used? But I do want to highlight one thing about aging well in the community. This is a picture I took of an individual, happens to be in Buenos Aires, but was on the city tour getting talked about the statue behind, which is a statue of Mendoza, but my attention was drawn to this fellow who you would recognize as sort of, you know, the stereotype street person, dirty, shabby clothes, the shopping cart, but he had a piece of bread. And he was feeding this bread to the pigeons. And so in my self-righteous way, I was saying, well, what are you doing feeding that bread to the pigeons when you could be eating it yourself? You know, you're homeless, you're probably hungry. Why aren't you eating it? And then I realized that for that 10 minutes, those pigeons were his friends, that something was loving him. And then I thought a bit more and I realized, and for that 10 minutes, he had a meaning in life. Those pigeons depended on him. And that's what we often forget. Happiness theory sort of tells us three things. In order to be happy, we need something to do, something to look forward to, and someone to love. Not someone to love you, but someone to love. Someone to love you might be number 4. But what it talks about is the meaning in life, having a reason for existence. And so in COVID times, we've talked and heard terms of, pejorative terms about, we warehouse people, we warehouse elderly people, we put them in buildings and they sit there, waiting till the end of their lives. Well, the same thing could happen in the community as well if you don't have a meaning. And so in some societies, for example, in Japan, an elderly person will be approached by the community and asked, could you be in charge of just cleaning this part of the street, keeping it clean? Now that person has a purpose in life. Even in long-term care, sometimes the residents are given tasks. Could you arrange the chairs after the meal? Could you arrange the books? And now the person has something to do and meaning. Of course, unfortunately with COVID, the something to do and something to look forward has been taken away from us. And so it turns out that as we age, having meaning in life is equally important, in fact, even more important than when we are younger. So those are some of the ways in which we could rejig our services to help seniors age well, which brings us then, how do we create this organization or Alberta-wide community-based seniors serving sector? Well, remember we said the resources exist. It's just we don't either know about them or coordinate them. So that's the key, is knowing and coordinating. So for example, there are initiatives such as introduced in the spring, the Healthy Aging Core Alberta, which is the website where the various organizations and even individuals can go to find out what services are, services in a particular area, opportunities for volunteering, to exchange ideas, and to start providing some of this organization. And as you can see, this is from the core website. All sorts of services are available through this. So we are starting to try and organize this. WHO, again, in terms of looking at integrated care, which is what my job title says I do, it talks about putting people and their needs first, or seniors and their needs, reorienting our care, reorganizing the delivery of services, engage carers and families, rearrange accountabilities. Right now, there's no accountability for a number of seniors, for example, that end up in emergency or end up in hospital or end up in long-term care when they could have been managed in or looked after or helped to live in the community. Nor is there incentives necessarily. Number one human resource, number one job in the world in terms of growth is care provider or personal care attendant. So all of these sorts of things from World Health talk about what we're trying to do. And then the last item, the last recommendation, is looking at the government to increase the proportion of spending on home care. And there's a bunch of numbers here. I phrase it a different way. I say, let's defund hospitals. To heck with the police. Let's defund the hospitals. If anybody here, if my bosses from AHS are here, please look at the asterisk. But what it's really talking about is exactly what the recommendation says is, you know, stop investing in acute care and let's look at keeping people out of hospital. So I'm just going to very quickly ask you, what do you think is the largest hospital in Alberta? Royal Alec Hospital, Foothills, University? It's this hospital. I don't know if you recognize it. This is the Strathcona Community Hospital. It's the largest hospital in Alberta. It has 25,000 beds. Can you imagine that, a hospital, 25,000 beds? The only difference is that these beds actually are in the community. So Strathcona Community Hospital, you see in there an emergency department. It has a full-blown emergency department, exactly the same as the Royal Alec, the Foothills, the University Hospital, Red Deer Regional Hospital, you name it. And it sees exactly the same type of patients as a nearby other hospital, which will go nameless. The only difference is that of the people that show up in the Strathcona Community Hospital emergency, 3.4% of them end up being admitted, albeit to other hospitals, versus the other nearby hospital where 11.4% of people are admitted. What's the difference? Well, like Strathcona Community Hospital, when you have no inpatient beds, you're forced to look after people in the community. It can be done. So just to finish up then, just wanted to highlight, remember that every system is perfectly designed to get the results it gets. We have the current system, we're getting the results we've designed it to. Our system is not broken. We built it this way. We need to unbuild it and build it a different way. And just to finish on some good news, it actually turns out that in Alberta, we are starting to reduce the number of people that are being, seniors that are being institutionalized and are looking after more people at home. So the orange line is the number of continuing care spaces, DSL and long-term care per 1,000 people. So although the absolute number is slowly increasing, the proportion is decreasing. And we're hopeful that in future, just like that recommendation, we're going to be shifting and putting our emphasis on long-term home care or care in the home, which is that big 67.6% bar, and be less reliant on institutionalization. So getting back to the vision, what did it talk about? Person-centered care, choice, independence, wellness, living well and happy, integration of health and social services, shifting services to the community, enhancing community capacity, and then respecting diversity. So I think we're on our way to doing this. We're trying to do it, a lot of work to do, a lot of help needed, but I think there's a reason for optimism in the future. So I'll finish there and be happy to answer any questions.
I have to say thank you to Richard. When we were planning these this webinar, I knew that Richard Lewanczuk was the person who knew the most about this, has the most experience, and you can see why. So somebody's just asked, will all the slides be available? Can we make those available, Richard?
Oh yeah, you're quite welcome to my slides.
Oh.
And there, Sharon, it's Lynn, there is going to be a recording as well. So if any of the folks on the line want to share it with their colleagues, there will be a recording with the slides included.
And another person asks, how do we lower the resistance to referring to and utilizing services provided by businesses?
Yeah, that's. I guess we live in a democratic society, and there's always a little bit of this sense of taintedness if we deal with business or private enterprise, but it exists. It's out there. We have our choice. Even in terms of living in particular sites, as we age, we have choice. We want choice. That's one of the principles. Many people would like to be able to have an opportunity to choose the care and the way in which they receive care, and so we can save for the future, hopefully, or for as we get older, and sometimes we need that safety net. It's how we sort of as the society decide what's important to us and how we would like to have our independence, I guess.
And another question is that what's the projected integration of palliative care services in the community? And that may be answered later in the Living Well with Palliative Care. But so what's is that?
I think that'll probably be answered, but I just quote the figure that 70% of Albertans die in hospital. 70% of Albertans would rather not die in hospital. So again, the same principle applies. Being able to stay in one's home and within the community, even in palliative stages. So there's certainly an awareness there, but I think that will probably come up in the palliative section.
We don't, do we inform the services or seniors of the choices available?
It's probably, somewhat sporadic. In the process, so we don't do a job like Denmark, for example. We don't systematically go out and do that. So it's a little bit hit and miss. We hope to change that. We hope, for example, that in primary care, through our primary care networks, and through the concept of the medical home or the health home, that as people age, those opportunities and options will be made available and people will be informed of them. We try to do it from a system perspective when people contact home care or other resources. But again, it sort of goes back to the very first question. Sometimes, for example, it used to be that 211 couldn't list private resources for people. But people want the full gamut of resources, so I think we're wanting to head in that direction.
And that answers the next question, because somebody says that oftentimes the directories won't include them, and 811 won't refer to private services. So
yeah, it's very interesting. So if democracy is topical these days, many of you may have been. I remember giving a talk about 3 years ago, and I didn't quite feel comfortable with not listing those services because people need to know and want to be able to have choice. And so we took an audience poll about who thinks that that private services should be made available. Not that you have to take them, but just as an option to people when you phone 211 or within directories versus not be available. There wasn't one person who put up their hand for not listing them. So 100% of people said that they should be listed.
all right, and I think that's our last question.
Well, thanks everybody, and thanks for hanging in for a few extra minutes because we got started a little bit late. Thank you so much, Richard and Sharon, for putting this presentation together. Just like to make you aware, if you haven't registered already, that the next session will be next Thursday, January 21st at 12:30, Living Well in Supportive Housing. And that does include the whole gamut, not just supportive living. So we're looking forward to that one. There will also be an evaluation at the very end of all of the sessions that you'll be hearing from us. Bye, everybody.